Good morning. Our lecture today is about muscle diseases. A muscle disorder. A muscle disorder includes patterns of weakness, loss of muscle tissue, EMG findings or electromyographic findings, or biopsy results that suggest muscle problem. The muscle disorder can be inherited, such as muscular dystrophy, or acquired, such as alcoholic or steroid myopathy. Medical name for muscle disorder is myopathy. So, to make it in a simpler way, muscular disorders is a muscle disease confined to the muscle itself, not due to another affection, not due to a nerve affection, not due to upper motor, meaning brain and spinal cord affection. It has to be a muscle disorder. We find in this disorder weakness of the muscle with a special pattern that we are going to describe later, loss of muscle tissue, meaning atrophy, EMG findings, which is neurophysiological findings, and muscle biopsy abnormality. What are the types of muscle disorders? The types of muscle disorders, it can be inflammatory myopathy, like polymyositis, dermatomyositis, and inclusion body myositis. We have muscular dystrophies, like Duchenne and Becker muscular dystrophy, limb girdle myopathy, congenital muscular dystrophy, facioscapulohumeral, myotonic syndromes, which is myotonic muscular dystrophy, congenital myopathies like central cord disease, Nemaline myopathy, myotubular myopathy, metabolic myopathies like glycogen storage diseases, mitochondrial diseases, and periodic paralysis, endocrinal myopathies like in thyroid abnormalities, parathyroid abnormalities, adrenal abnormality, and pituitary diseases. And we have the drug-induced or toxic myopathies. First, we're going to talk about inflammatory myopathies. Inflammatory myopathies includes polymyositis, dermatomyositis, and inclusion body myositis. And it is a muscle disease with weakness and inflammation of muscles with or without pain. Polymyositis and dermatomyositis are disorders of connective tissue. It includes tendons, ligaments, dense sheets of collagen-based tissue that cover the ends of the muscles, and it causes swelling and tenderness of the muscles. It is an inflammation. And sometimes there is skin affection, and in this case, it is dermatomyositis. So dermatomyositis is polymyositis with skin affection. What are the clinical picture of polymyositis and dermatomyositis? We have periorbital edema and discoloration, which occurs in polymyositis and dermatomyositis accompanied with diabetes mellitus. We can have dysphagia and dysphonia in 20% of cases. There is muscle tenderness and weakness in about 50% of cases. The tenderness is in 50% and the weakness is in all cases. Interstitial lung disease in 20% of cases. We can have diaphragmatic weakness with shortness of breath. Here the muscle biopsy can show inflammation, necrosis. In the hands we have ragged cuticles with periangle erythema, hyperkeratosis and scaling, and we have red scaly erythematous or violaceous papules called Gottron's papules. Inclusion body myositis is a progressive muscular disorder. It is characterized by muscle inflammation, weakness, atrophy. It is a type of inflammatory myopathy that develops in adulthood, usually after the age of 50, and the symptoms and rate of progression vary from person to person. What are the clinical features of inclusion body myositis? It's the most common acquired myopathy after the age of 50 years. It is slowly progressive with atrophy and asymmetric, predominantly affecting the finger flexors, hip flexors, and knee extensors, and affecting the males more than the females. So it's above the age of 50, males more than females, slowly progressive, with atrophy and predominantly affects the finger flexors, hip flexors, and knee extensors. The next type of muscle disease is muscular dystrophies. We have several types of muscular dystrophies. It's a genetic disorder of muscles. Muscular dystrophy causes the muscles in the body to become very weak. Here we can see Gowers' sign. Gowers' sign when we say that the patient climbs upon himself. When we ask the patient to come out from or to come up from sitting position or from the ground, he starts by putting his hands on the ground to support himself, then putting his hands on his legs and coming up gradually by putting one hand above and then the other until he stands up. So we call it that the patient is climbing upon himself. Okay, these are the muscle groups that are affected in different muscular dystrophies. The first one, Duchenne and Becker muscular dystrophies. We have the proximal groups of muscles in the upper and lower limbs. And in the lower limbs, we have affection of the calf muscles, which is a very characteristic picture in Duchenne and Becker muscular dystrophy. There is pseudo-hypertrophy of the calf muscles. What do we mean by pseudo-hypertrophy? Pseudo-hypertrophy is apparent hypertrophy, or we see it as hypertrophy, but there is weakness. So it is hypertrophy with weakness. The next group of muscular dystrophies is the limb girdle myopathy, and it affects the proximal groups of muscles in both upper and lower limbs. The facioscapulohumeral muscular dystrophy affects the proximal group of muscles in the upper limbs. It affects the facial muscles and it affects the calf muscles. And Emery-Dreifuss muscular dystrophy affects proximal group of muscles in the upper limbs and the calf muscles in the lower limbs. The most important muscular dystrophy that we face is Duchenne's muscular dystrophy. It's the most common. It's X-linked recessive disorder with onset before the age of 5 years or between 3 and 5 years. It affects males, and as we said, it's X-linked recessive, and it affects about 30 per 100,000 live birth males. It's due to deletion mutation of the gene that encodes dystrophin. What are the clinical manifestations of Duchenne muscular dystrophy? We said that the age is before 5 or 3 to 5. It's progressive weakness with pseudo-hypertrophy of calf muscles, and as we said, pseudo-hypertrophy meaning hypertrophy with weakness. There is spinal deformity. There is cardiopulmonary involvement and mild to moderate mental retardation. slowly progressive but continuous. The muscle weakness occurs in the lower limbs first than the upper extremities. The patient is unable to move at the age of 10, between 7 and 12 years, and death usually occurs from pulmonary or cardiac failure in the second to third decades of life. Becker muscular dystrophy. It's very like to Duchenne muscular dystrophy, but at a later age group and a less severe form. So it's less common, 1 to 300,000 live male births. It's less severe. The patient may have a family history of atypical muscle disease, similar and less severe than Duchenne muscular dystrophy, as we said. It occurs at a later age, more than 7 years of age. There is also pseudohypertrophy of the calf muscles. There is skeletal deformities of the foot, equinus and varus. There is also deformities of the spinal cord or the vertebral column, high rate of scoliosis, and there is less frequent cardiac involvement than Duchenne muscular dystrophy. How do we diagnose it? Both of them, Duchenne and Becker muscular dystrophy, there is elevated CPK, creatine phosphokinase, which is a marker of muscle destruction. It's more than 200 times the normal. There is decreased dystrophin or altered size. Becker muscular dystrophy has slower progression, and the patient can ambulate till adolescence with longer life expectancy, and the treatment is the same as Duchenne muscular dystrophy with the forefoot equinus, plantar release, midfoot dorsal wedge osteotomy. There are other types of muscular dystrophy, as we said before. We have the facioscapulohumeral. It's most commonly seen in teenage years and begins in shoulder and face, as we said, and the patient can't fully close their eyes. So it affects the face, the shoulders, and it also affects the lower limbs, as we said before. Limb girdle, it affects the proximal muscles of both upper and lower limbs and starts in childhood or teenage years. The patient here has trouble raising the front part of the foot with tripping or falling a lot. Oculopharyngeal myopathy, the onset is later at the age of 40 to 70 years of age. The eyelids, throat, and face are affected first, and then the shoulder and head. What are the treatments for myopathies? There is no cure. You can improve the symptoms and slow the progression down, but not fully cure it. There are testing on gene therapy. Gene therapy is the transplantation of normal gene into the cells in place of the missing or defective cells. So, there is no specific treatment for muscular dystrophies, but we can help the patient by physiotherapy, and by correcting of the skeletal abnormalities that they have. Myotonic muscular dystrophy. Myotonic muscular dystrophy is a genetic disorder that affects muscle function. It's a type of muscular dystrophy. The symptoms include gradually worsening muscle loss and weakness. The muscles often contract and are unable to relax. Other symptoms may include cataract, intellectual disability, and heart conduction problems. The most prominent symptom here is weak relaxation of the muscles. As we said here, the muscles contract and are unable to relax. It's very embarrassing for the patient because when he starts to shake hand with anybody, he is unable to relax his hand and still is grasping the hands of others. So it's a very embarrassing symptom for the patient. What are the clinical picture of myotonic muscular dystrophy? The patient has frontal baldness, cognitive impairment with apathy and hypersomnia, cataract, hypothyroidism, conduction defect with arrhythmias and cardiomyopathy, and this is the main cause of death at a later age. There is glucose intolerance, GIT disturbance, infertility and testicular atrophy, and there is the myotonic contraction of the muscles with muscle wasting and myalgia or muscle pain. And there is elevated risk of cancer in this patient. Congenital myopathies is another type of myopathy. These are rare muscle diseases mostly present at birth that result from genetic defects and most share common features including lack of muscle tone and muscles and weakness. Other signs and symptoms of some congenital myopathies include feeding and breathing difficulties. And this is the most important symptoms and signs in these patients because the patient at birth cannot suckle, has breathing difficulty, and may die according to the severity of these symptoms if they are so severe. He also has skeletal conditions such as curvature of the spine, scoliosis, weak bones, hip problems. Signs and symptoms of congenital myopathies may not be apparent until later in infancy or childhood. So congenital myopathies can be very evident at birth with feeding or suckling and breathing difficulties and may lead to birth if so severe and can present at a later age in infancy or childhood. This is the picture of the patient at birth. He is floppy or there is muscle atony, decreased muscle tone. Metabolic myopathies is a group of hereditary muscle disorders caused by specific enzymatic defects due to defective genes. Metabolic myopathies are heterogeneous conditions that have common abnormalities of muscle energy metabolism that result in skeletal muscle dysfunction. It's caused by three main disorders: glycogenosis, lipid-related disorders, or mitochondrial diseases. Endocrinal myopathies. These are myopathies caused by endocrinal problems like thyroid problems, hypo or hyperthyroidism, adrenal disorders, Cushing and Conn's syndromes, parathyroid disorders, hypo and hyperparathyroidism, pituitary disorders, diabetes, and vitamin D deficiency. The cardinal features in this type of myopathy is muscle fatigue. CK, serum CK or creatine kinase, EMG, electromyography, and muscle histology are normal, except hypothyroidism, there is CK elevation. And they all respond to treatment of the cause. If we treat the endocrinal problem, there is muscle improvement. Drug-induced myopathy, we have many drugs that affect the muscles. We have lipid-lowering agents, we have glucocorticoids, and we have drugs of abuse and related myopathy, like alcohol, amphetamines, cocaine, heroin, phencyclidine, mipridine. They cause rhabdomyolysis and myoglobinuria. And we have non-depolarizing blocking agents, neuromuscular blocking agents, which cause acute quadriplegic paralysis. And we have drug-induced autoimmune myopathies with D-penicillamine. It can cause polymyositis or myasthenia gravis. And we have others like amiodarone, chloroquine, hydroxychloroquine, and colchicine that cause proximal muscle weakness. Okay, this is the end of the first part of our session, which is muscular disorders. Then we have neuromuscular junction disorders. The neuromuscular junction is the junction between the muscle and the nerve. It is responsible for transmission of impulses from the nerve to the muscle. So it is a chemical synapse between motor neuron and muscle fiber, and it allows the motor neuron to transmit a signal to the muscle fiber, causing muscle contraction. What is the myoneural junction formed of? It's formed of terminal button, presynaptic membrane, synaptic cleft, and postsynaptic membrane. Here we have vesicles. These are the vesicles that gather at the presynaptic membrane. This is the presynaptic membrane, and it's containing acetylcholine that is released in the synaptic cleft, this area. It comes out through voltage-gated calcium channels, and we have to remember that it is voltage-gated calcium channels because it's very important later on. Synaptic cleft is the distance between the presynaptic and postsynaptic membrane. It's 50 to 100 nanometer wide and contains extracellular fluid and contains acetylcholine esterase. Acetylcholine esterase is the enzyme that hydrolyzes acetylcholine into acetate and choline. What's the importance of such enzyme? Its importance is that it gets rid of the excess acetylcholine to stop muscle contraction, because if you have acetylcholine continuously in this synaptic cleft, there will be a continuous muscle contraction without stop. So we have to get rid of the remaining acetylcholine that is in this area. Then we have the postsynaptic membrane. Postsynaptic membrane contains acetylcholine receptors. These are the receptors that receive acetylcholine that is in the synaptic cleft. And it contains voltage-gated sodium channels. We said that the presynaptic membrane contains voltage-gated calcium channels, while the postsynaptic membrane here contains voltage-gated sodium channels. Okay, this is another picture of the presynaptic and the postsynaptic membrane and the synaptic cleft. Altogether, they are called the myoneural junction. Okay, we can see here the fusion of the synaptic vesicles to the presynaptic membrane, and then they are released in the synaptic cleft, and then it goes to the acetylcholine receptors in the postsynaptic membrane to mediate the impulse. Neuromuscular transmission. What is neuromuscular transmission? It is transmission of impulses from motor neuron, the motor nerve ending, to skeletal muscle fibers. So as we said, it is the junction between motor neuron and skeletal muscle fibers. And this is the myoneural junction responsible for neuromuscular transmission. What are the disorders of this area or the neuromuscular junction? First and most important is myasthenia gravis. It is a neuromuscular disorder characterized by weakness and fatigability of skeletal muscles. And fatigability here is a very important symptom and sign. It's an autoimmune disease in which antibodies damage and destruct acetylcholine receptors at the neuromuscular junction. So the damage here in myasthenia gravis is to the acetylcholine receptors at my neural junction, the receptors. And as we said, the receptors are in the postsynaptic membrane. So there is decrease in the number of acetylcholine receptors at the neuromuscular junction. Although acetylcholine is released normally, leading to failure of generation of action potential in the muscle fibers. So here, the presynaptic area and the synaptic cleft have no abnormality. They release acetylcholine normally. The abnormality here is in the postsynaptic membrane containing the acetylcholine receptors. The antibody is against the acetylcholine receptors. The amount of acetylcholine released per impulse also declines on repeated activity because in a trial of the presynaptic membrane to maintain the action potential or to initiate the action potential, there is continuous release or extra release of acetylcholine. With presynaptic rundown of acetylcholine, so it gradually decreases with repeated activity, resulting in activation of fewer and fewer muscle fibers by successive nerve impulse. And this is responsible for fatigue. Fatigue is the main symptom of myasthenia gravis. Fatigue in the form of, with repeated activity, the patient cannot maintain the action anymore. How the autoimmune response in myasthenia is initiated is not completely understood. However, the thymus appears to play a role. And in 10% of patients, we have thymic tumors. What are the clinical features of myasthenia gravis? It can affect all age groups. It's more common in women, especially in their 20s and 30s. It can affect men also, but at a later age in their 50s and 60s. Cardinal features are weakness and painless fatigability of muscles. Fatigability is repeated again because it's the key point in this disease. Weakness increases on repeated use of the muscle or exercise and improves following rest. So the symptoms are worse towards the end of the day with repeated use of the muscle and less in the morning after rest or after sleep. Distribution of muscle weakness often has a characteristic pattern. The lid and extraocular muscles are involved early in the course, followed by facial weakness and muscles involved in mastication and speech. The most frequent presentation is with ptosis and diplopia. And in 85% of patients, the weakness becomes generalized, affecting the limb muscles as well. So it starts usually with ptosis and diplopia and can be confined to this area without generalization. What are the signs of myasthenia gravis? We have peripheral signs, having weakness, particularly of the arms and proximal muscles of the legs. We have permanent myopathic wasting that may occur in long-standing cases. Facial affection with lack of expression and ptosis, we call it myopathic facies. We have bulbar affection. We can have dysphagia, difficulty in deglutition, dysarthria, difficulty in talking, and difficulty in chewing. Rarely, we can have respiratory affection, and respiratory crisis may occur and may be the cause of death in such patients. What are the ocular features of myasthenia? 90% of patients have both ptosis and weak extraocular movements. Ptosis is usually bilateral but asymmetrical. It increases on prolonged upgaze, which causes fatigue of the muscles. Prolonged upgaze, we mean more than 30 seconds. We have a specific sign, Cogan-Twitch sign, which is a brief upshoot of eyelid when the patient looks straight ahead after looking down for several minutes. So, we make the patient look down for several minutes, then look straight ahead. At this time, we can see upshoot. It's a brief upshoot of eyelids. We have the positive ice test. If you put an ice pack on the eyelids for 2 minutes, this results in an improvement in the severity of ptosis, because cold improves neuromuscular transmission. Diplopia. Diplopia is frequently vertical diplopia, which means that the patient sees the two images above each other, although any or all of the extraocular muscles may be affected. When myasthenia is limited to the ocular muscles with no generalized involvement, it is known as ocular myasthenia. As we said before, generalization occurs in about 85% of patients, while about 15% of patients it may remain with ocular affection only. These are the signs and symptoms of myasthenia. We have diplopia and ptosis. What are the investigations for myasthenia? We have, we can estimate the serum anti-acetylcholine receptor antibodies levels. We said that we have antibodies against acetylcholine receptors. So we can see the serum level of these antibodies. The presence of anti-acetylcholine receptor antibodies is diagnostic of myasthenia, but a negative test does not exclude the disease. We have a type called seronegative myasthenia. We call it seronegative, where there is negative test of this antibody. We have to make a thoracic CT or MRI to detect thymoma. As we said, we have thymic tumors in about 10% of patients. Electromyography is diagnostic for myasthenia, but it is the latest. It's the most sensitive, but the latest. What do we see here? We see, we do a Dacrymen test. This Dacrymen test gives us a picture called diving bomb test or diving bomb sign. Diving bomb, there is muscle contraction, which is very strong at first, and then it gradually declines. Hydrophonium test or tensilon test is also used in diagnosis of myasthenia gravis. What's the treatment of myasthenia gravis? We have anti-choline esterase medications like pyridostigmine, which is most commonly used, and it starts at a dose of 30 to 60 milligrams 3 to 5 times a day, increased or decreased as per patient's response. Thymectomy to remove a thymoma if present, also tried as a treatment in generalized myasthenia gravis. Immunosuppressants are also used, like steroids or azathioprine, and cyclophosphamide in refractory cases. Plasmapheresis and intravenous immunoglobulins are also used in myasthenic affection, especially in myasthenic crisis. The second type here is Lambert-Eaton myasthenic syndrome. It's also an autoimmune disorder of the neuromuscular junction, often associated with small cell carcinoma of the lung. The systemic features here include gradual difficulty in walking that may precede clinical manifestations of the associated carcinoma by up to 2 years. So we can have this type of myasthenic syndrome, the Lambert-Eaton myasthenic syndrome, before the appearance of small cell carcinoma of the lung by 2 years. Ophthalmic features here are also ptosis and diplopia. We have antibodies here against calcium channels present on the presynaptic membrane. So, as we said in myasthenia gravis, the antibodies were against the acetylcholine receptors in the postsynaptic membrane, while in Lambert-Eaton syndrome, the antibodies are against calcium channels present on presynaptic membrane. The calcium influx here decreases and decreases the release of acetylcholine. So if there is decreased release of acetylcholine, as we remember in myasthenia gravis, there was normal release of acetylcholine, but the problem was in the acetylcholine receptors on the postsynaptic membrane. So we have to remember the difference between Lambert-Eaton syndrome and myasthenia gravis. So here is the difference between Lambert-Eaton myasthenic syndrome and myasthenia gravis. In Lambert-Eaton, the antibodies are against the nerve where acetylcholine is released, the presynaptic membrane. While in myasthenia gravis, the antibodies are against the muscle receptor for acetylcholine. In Lambert-Eaton, we have it starts at the extremities and moves up, while in myasthenia, it starts at the eyes and moves down. And in about 15% of cases, as we said before, it may affect the eyes only without moving down. In Lambert-Eaton, the weakness improves with activity, but in myasthenia gravis, the weakness worsens with activity. Lambert-Eaton is associated with small cell lung cancer, while myasthenia is associated with thymoma. Lambert-Eaton is treated with aminopyridines, while myasthenia is treated with acetylcholine esterase inhibitors. Thank you very much.